Today I'm going to talk a little bit about how we think the pausing of breast cancer screening has affected or may affect outcomes over the years. I'm going to start a little bit, though, with a sort of an update on the AO project number 2, which is the masking risk project, which we've been working on for the past few years. And really, the motivation behind any of our work is improving breast cancer screening. And the reality, though, is that screening mammography will fail sometimes to find certain cancers. And this is especially true in the so-called dense breast. And I've got an example of a mammogram with a particularly dense breast shown here. And, it's what, the trick is to find these subtle white lesions in a white background, and they're very hard to find. So we've been working on a radiomic-based masking risk indicator that identifies uninformative mammograms, so mammograms that really aren't going to tell the radiologist anything. And the idea is that if we use this in a stratified program, we could redirect women who have high masking risk to some kind of alternative screening modality that might work a little bit better in the dense breast, but maybe isn't as accessible or as available as mammography would be. So just to sort of illustrate what a stratified screening program would look like, women would come in for her mammogram. If they're identified to be high risk of masking, put them into an alternative stream where they would get maybe ultrasound or MRI or some other modality. And the idea there is that we would reduce the number of missed cancers overall, and in so doing, improve outcomes for all women in the program. We've developed this masking risk indicator that analyzes the images and essentially evaluates the detectability of simulated lesions in the mammogram. And what we're trying to do is increase the number of detected cancers and reduce the number of missed cancers. And we refer to that as the capture fraction, shown on the graphic on the top left, or the top right, sorry. And we want to do that in an efficient way because, the easiest thing to do if we had tons of money and tons of time and resources is just have everybody do lots of extra imaging, have everybody do an ultrasound, an MRI, and a mammography, and throw in everything else into the mix. But that's obviously not efficient. A lot of time and effort and money would be involved. So we want to do this with, essentially only recruiting as few women as possible into this alternative screening program. And then this is just example shown here where we're looking at the performance of our screening risk indicator in terms of the capture fraction, reducing the number of missed cancers, and how many women, or the fraction of women that would need to be screened. So just in a very brief update here, we are exploring now taking this and putting it into the clinic. And so we're looking at, with help of the clinical trials group, as to whether or not we can put this together in the auspices of OICR. And we're, of course, looking for Canadian sites that might be interested in participating in such a sort of prototype or pilot screening program. And also we have continuing and growing collaboration with Cambridge University, who have a large cohort in which we can evaluate the effect of the masking risk. So this is great. We're trying to really reduce sort of underperformance in screening mammography, but this is sort of becomes a moot point if screening stops. And in 2020, because of the pandemic, a lot of jurisdictions actually canceled anything that was considered to be elective or non-life-threatening, such as breast screening programs, and they were essentially stopped for anywhere from 3 to 6 months in 2020. So it kind of doesn't matter if we have a stratified screening program if we're not screening. So to give you some numbers, and I'm sure everybody's very familiar with some of these numbers, but if we take a look at COVID-19, this is back in 2020 when we published a paper on the effect of the pandemic pause on screening. There were 178,000 cases, and at that point there were 9,500 deaths in Canada. To give you an idea of perspective, in breast cancer in Canada, in any given year, there are about 27,000 new cases and about 5,000 deaths on a year-over-year basis in Canada. And so that's with a functioning screening program. Now, just to point out that as of yesterday, we're up to almost getting close to the 1 million mark in terms of the number of cases, and the number of deaths have skyrocketed quite a bit in Canada. 22,000 at the last count here, and that works out to roughly, by my calculation, about a 2.5% crude mortality rate. So that's a fairly high rate of death, and in fact, I think these numbers brings it into the category where this is the I think the second or third leading cause of death in Canada. So these numbers start to be big, but we also have breast cancer screening that's going on that is not being that was not being done in 2020 for a period of time. And just from reference numbers, there's about 37 million or 38 million people in Canada, and women of screening age, there's about 6.6 million. So how do you estimate the effect of pausing or stopping screening? And this is something that people hadn't really looked at in the past, because there was no expectation that screening should stop or be paused for such a situation. So there's really no studies that we can kind of look back to and say, oh well, we know that this is going to cause this many more cancers to be found at later stages, and it's going to cause higher mortality or lower mortality and so on. And even if you look at it in where you look at women who are don't attend screening on a regular basis and maybe go sporadically, what their sort of what that impact is on their mortality. And so we don't really have a lot of answers there. Now, I should point out that just as of last week, there was a paper that did actually examine on a very large cohort in Sweden whether or not the mortality risk is the same or different for women who attend every screening appointment, or those who forget to go 1 year, miss a year, and then come back later on. And what they showed is that the lapsed or intermittent participants don't get as big a mortality reduction as those who do attend every screening visit. So when we have questions like this, sometimes something that we can do is called population-based modeling. And that's what we published a paper on with a group from the Canadian CPAC, and as well as the British Columbia Cancer Agency, University of Alberta, and ourselves. And the Canadian Partnership Against Cancer is a federally mandated group that tries to coordinate and effect systemic changes in across jurisdictions and organizations to improve all cancer outcomes. So in terms of reducing the incidence of cancer, prevention, reduce the likelihood of dying, and so on, and trying to bring collaborations together for that. And one of the tools they've developed is called the OncoSim model. And this is for a model that actually takes all of the data from Canadian populations and brings it into a simulation where they simulate one individual at a time. So if the system is running at full tilt, that would simulate 37 million people living in 2020. And the idea is that if this model is predictive, that and it can actually show that it gives the outcomes that we see in the actual data that we see in the cancer registry and populations, the Statistics Canada, and so on, then perhaps you can fill in information whenever there's gaps in the data that we have as to what happens if we change a screening program, what happens if we change or add in a new cancer prevention strategy. And we worked on that with the idea of looking at the pause in screening. Now, OncoSim is a very, very complex model. It has 32 cancer sites that were identified that have various inputs and parameters to create the simulation. And there are 4 so-called in-depth models that are very, very sophisticated models for breast, colorectal, lung, and cervical cancers. And these in-depth models have a whole host of input factors. And they could be the risk factors for each person. It could have screening or prevention strategies, treatment outcomes and probabilities in terms of survival, and so on. And these are all fed into the model. And then at the outcome or the outputs from the model, we can see things like cancer incidence over time, by age group, by subgroup of different genetic factors and so on, and see how that changes with these parameters that are changed in terms of cancer incidence, cancer deaths. And one of the other things too at these population level is what is the cost to society in terms of quality adjusted life years and the cost for the economic cost for providing these changes or interventions. This is so-called a natural history model where we actually, each person is represented in the simulation, and they're given a probability at each age of either developing cancer or dying from other causes, and going through the entire life cycle or lifespan of that individual, and then recording it and collecting all of that statistics for all of that information. And here's the breast cancer model sort of inputs, just sort of very briefly. It's a very complex model. It takes into account a number of things. The breast cancer model is actually very interesting in that once the cancer is so-called assigned to the individual or develops in the individual, there's a tumor growth model. And this growth model is used to sort of have the cancer grow over time and to be the driver, if you like, for spread, development, metastasis, and then survival and outcomes from that. And this also impacts on cancer screening. So if the cancer is too small, we don't find it. But once it gets large enough, we will find it either in mammography or in some unfortunate cases, just by clinical symptoms and signs when the cancer gets too large. So this tumor growth model is interesting because it's a sort of a simplification of the whole biology of what's going on there. But essentially what they're doing is the tumor grows over time. And so at each time point in the model or the simulation, the tumor gets a little bit bigger, and that's defined by a certain growth rate that has a variable parameter so that it sort of incorporates very aggressive cancers and not so aggressive cancers. And that size then in turn dictates the probability of whether or not the tumor becomes metastatic and in terms of outcomes of survival, detection, progression, relapse, and so on. And this is something that's worked quite well in another model that is in the CISNET group, the so-called Wisconsin breast model, with the sort of the added input factors that we need for the Canadian statistics in terms of incidence, mortality, staging, and survival outcomes. Just quickly to show you that one of the important things when you're doing modeling like this is you need to validate it against real data. And here's just sort of two examples of that validation where we see that the OncoSim model, when we model 37 million people and we look at the breast cancer component, we can see that the incidence of invasive cancer is more or less correctly predicted for age group, and even by the various provinces and territories where the women might be living or are growing up and living out their life. So now we can do the model, and we're looking at a screening interruption model where we make some very, very highly simplistic assumptions. So number one is that there's no change in screening behavior, meaning that the women who would normally be screening prior to the COVID interruption will continue to screen after the COVID interruption. Also, we assume that there were no delays in diagnosis or treatment, so there would be no change in sort of the resources or the facilities available if a cancer is diagnosed, and so on. We also didn't actually incorporate the COVID mortality into the all-cause mortality model, so women aren't going to be dying of COVID in this model, because at the time we didn't really have any proper statistics for that. And it's very, very simplified in terms of what the screening protocols are. Screening protocols and screening programs are different from province to province. Sort of when you start screening, who gets screened, and what kind of screening you get has been simplified. And a model that has worked well to sort of predict across Canada is a combination of biennial screening every 2 years, and for some women who are identified at increased risk, for annual screening. And that seems to work well at matching the outcomes across a number of provinces. So the idea is normal screening happens prior to 2020, And then all screening is halted. And at the time when we were doing this, we didn't know how long the lockdown was going to last. So we did a 0, 3, 6, and 12-month interruption, and then normal screening resumed. And we looked at things like cancer incidence year over year, the staging of the cancers that eventually were found, and then the mortality for that. So here's the incidence staging over the few years following the interruption, at 3-month, 6-month, and 12-month interruptions. And you can see that in the year of 2020, because we're not screening, we don't find as many cancers. And there's a corresponding jump in 2021 or whenever the screening resumes. And we see there's a whole bunch of cancers that were not found the year before are now being found. And the other thing to note is that over that period in, say, the next decade, 2020 to 2029, there's a fairly significant upstaging where the cancers that they are finding, because it's a year or 2 years later, they're being found in stage 3 and above, or more cancers are being found in those stages. And there's a corresponding decrease in the number of earlier stage cancers. So when you find cancers later on, they're a higher stage, that will lead to an increase in mortality. And so this is a plot of the excess mortality cumulative over time after that initial interruption in 2020. And you can see for a 3-month interruption, say by the year 2030, you're getting to around 100 extra more deaths across Canada, whereas with a 12-month interruption, we're getting closer to 500 or 600 at that 1 decade sort of anniversary. So that model that we did, we basically assumed normal screening would happen, there's the interruption, and then normal screening would resume, and that anybody who was sort of delayed in screening would still get a screening exam as soon as the clock started ticking again. And the difficulty with that is that, let's say that the screening resumed on August 1st, 2020. The women who would normally be scheduled for August 1st, 2020 would get their screening, but all the women who had been delayed would also get it on August 1st. And clearly that's not a practical answer. They have to be sort of slotted in whenever there's availability. And unfortunately, the other reality is that because of infection control concerns, staffing and occupancy have been drastically reduced in a number of these facilities. And so the throughput for patients has been altered. And on the other side, women may choose not to go get their screening mammogram because of fears of going into a hospital or to a medical clinic and coming in contact with others. And so they may not be interested or prioritizing that in terms of returning to regular screening. And so what we did is we did a second model where we had this transition period that could be anywhere from 6 months up to 2 years, where the reduced sort of capacity is running at, so say 50% capacity. And that sort of tries to mimic these two concerns. And when we do that, if we take a look at an example for the 6-month interruption, where everybody returns back to screening right away after that interval resumes, if we have this sort of transition period of 6, 12, and 24 months, you can see essentially it's just like if they had been closed down or paused for a longer period of time, and you see the excess number of deaths at each of those stages. And it's not quite linear, but it's more or less the longer the transition period, the more cumulative deaths there would occur. And this is just a table summarizing the data here for breast and colorectal cancers, which were the 2 cancers that we were reported on in our paper. And say 1 decade following the interruption, we see that if we only had a period of 6-month interruption, we'd see 250 deaths, perhaps by the year end, but that could be directly attributed to the pause. Whereas if we had this sort of 1-year transition model, which is something that we're starting to get a little bit closer to, even though after the interruption, we're getting closer to maybe 500 extra deaths. And that corresponds to about a 1% increase in mortality expected over that decade. There's not a lot of references to compare it to, but there was one early report in an editorial from the group in the States that are involved in the CISNET modeling program and Dr. Sharpless from the National Cancer Institute. And they showed a very similar thing, although the details aren't in the editorial, and they showed that there's about a 1% increase expected in the number of deaths for breast and colorectal cancer. So there's a whole bunch of study limitations. We can only do what the model allows us to do. Number one is there's a lack of comparative data. We don't know what the actual impact is going to be, and we're not going to know until maybe a decade from now as to what happens to breast cancer outcomes. And one of the big things that we couldn't change in the model was the treatment time, or the delay between diagnosis and detection and treatment. And in the model, that's sort of just a fixed parameter, and we couldn't change that sort of on a temporal basis. And I think that we're starting to see that, anecdotally at least, there are these delays that are happening because women are not able to get into a clinic because of workload capacity limitations, or they're choosing alternative strategies where they may be avoiding things like surgery or other treatments, and changing the treatment sort of prioritization, which we couldn't do in the model either. And then we assume no temporal limits. There's no thing saying, oh, this person gets screened on that day, and we'll allow as many women as possible to be screened on that day. And in reality is that there is logistical issues associated with that, and that is not in the model. And finally, the one really important one is it assumes that there's no changing in the screening behavior, meaning that women who were screening before will screen exactly the same way after screening resumes. And those aren't in the model. And so we got a piece of the answer, but probably not the whole story. And then just the acknowledgement slides. This is work that is a multi-person group, multi-center group, and is really provided by the OncoSim working group, and a lot of the work and effort that went into developing the model.